it's not enough that you go to the doctor who's the most impressive number of diplomas and does all the things in menopause. If they can't explain it to you in language that makes sense and for you to understand the logistics of how this is going to work, we're not getting anywhere.
Welcome to MENO with Jacqueline Buckingham, the authority on menopause, peri-menopause, and wherever you are on the pause spectrum. I'm Jacqueline Buckingham, founder of MENO, and firm believer that menopause is status, not a sentence. If you're here, something in your body or your life is asking for your attention, and you're not meant to navigate that alone. In our first 2 seasons, we started this conversation, won an Anthem Award, and brought you the leading experts before they were on Oprah. Now we're raising the standard. Each week, I bring you the verified providers, menopause specialists, and authorities you need to understand what's happening in your body and what to do next. From the gold standard in HRT and the little pink pill for sexual desire, to the conversations no one else is having about relationships, identity, and mental health. This is the full picture of your health, because this stage of your life is not just about symptoms. This is about how you live, how you feel, and how to embrace it all, because you have arrived. Pausing or not, start here. This is MENO with Jacqueline Buckingham.
I am so excited to announce my guest today. Dr. Rachel Rubin is a board-certified urologist and a sexual medicine specialist, and someone who is absolutely changing the landscape for women's health in general. She's an activist, she's an advocate for her patients, she is truly changing her patients' lives as someone who is committed to her patients and committed to changing healthcare in a way that I have never seen before. Here is my conversation with Dr. Rachel Rubin. Dr. Rubin, you are just not only a phenomenal advocate for women, you're really an activist that is changing the entire landscape of women's health. And that's why I'm so excited to talk to you today and to bring all of your knowledge here. So thank you, first of all, for being here.
Thrilled to be here. Oh my gosh, thanks for having me.
I want to dive into so many topics, but really what I want to start with is menopause. And you seem to have really the answers. And I've listened to so many of your videos and so much of your social media, which by the way is amazing. And if you're not following Dr. Rubin, it's Dr. Rachel Rubin on Instagram, and you have an incredible amount of information there. The thing that you talk about is you're like, this is actually something that until 2014 wasn't even really recognized as a syndrome. And now that it is, you have answers that seem like they're easy when I've experienced, just in my asking questions to my gynecologist and general practitioner, not a lot of simplicity. Can you just talk about how you handle menopause and perimenopause in general?
Yeah, I think we have a big problem in women's health where we don't talk about quality of life as an important thing to go up to your doctor for. We're pretty good at cancer screenings, cancer prevention, pregnancy, the important stuff according to society. And when you just don't feel good, when you feel tired, when you don't feel like yourself, when sex starts to not be what it used to be, we don't have a nice space in our current medical system to really address those issues. And women are hungry for answers to those questions. And so they go and spend billions of dollars on supplements and devices and all sorts of things to try to get answers, because patients are really desperate, because this really affects who they are as humans and how they interact with their loved ones. And so it's a lack of education that is out there in the medical community. It is a lack of our understanding of how to train which kind of doctor are you supposed to go to for these symptoms. And is it really appropriate to have a once a year medical visit for 10 minutes with your legs up in stirrups and that's it? That's the only medical care you get all year? Like, it's not acceptable. So we think of it in a different way.
That is just agreed 1,000,000% and amen. And oh my God, just hallelujah. It's amazing to hear this, because it is confusing to know, who am I supposed to ask about this? And is it appropriate? And like you said, we only have 10 minutes. So I know that you offer Zoom group chats about menopause, and I would love to just get into, how do we even know that what we're experiencing is perimenopause or menopause? How do we even know?
Yeah. And so this is where I'm trying. It is really hard. The only reason I'm good at what I do is two things. One, I spend a lot of time with people. Like my visits, if a one-on-one visit is an hour to an hour and a half, if you're in person, right? And they're long because I have to get to know you, to know what you care about and what your history is, to even figure out what is the customized approach that makes sense for you, because your care and your sister's care are very, very different. And so you need to find a doctor who is willing to just legitimately just listen. And in our current medical system, that is really, really challenging to do and to find those people. So not only do you have to find someone who knows you, but you have to find someone who actually knows what they're talking about. And not only do they have to know what they're talking about, but I've learned that they have to get you to understand what they're recommending and why it's important. So it's not enough that you go to the doctor who's the most impressive number of diplomas and does all the things in menopause. If they can't explain it to you in language that makes sense and for you to understand the logistics of how this is going to work, we're not getting anywhere. So we've tried a few different strategies because I believe you can't take hormones because Rubin tells you it's a good idea. You have to take it because you've educated yourself, because you understand the pros and the cons and the risks and the benefit, and you understand it for your own story, and you make good decisions about your own healthcare. Because I believe with education, people can make really good decisions about their healthcare.
Totally. Absolutely. And that is a piece that is so much a part of the puzzle, is basically the fact that doctors are not even educated in women's health because women's health is so far behind men's health. I'm pretty sure I heard you say that there's 27 specialties in men's healthcare, but not in women's. Is that right?
Specifically for sexual medicine. So we have 27 fellowships for men's sexual health, and even only one, now officially two, that even acknowledge women's sexual health care. And it was in urology, right? I did the fellowship. I'm a urologist, not even a gynecologist. And so we don't have the same rigorous research, the same level of evidence, the same intense science, because we don't value it as a society.
Right. So how can we as patients advocate for ourselves with our doctors? Can you tell us some of the things that are basically the symptoms of perimenopause and menopause so we know what to say to our doctors?
To your point, and you said this yourself, when you went to your doctor, they sort of looked at you like you wanted a back alley procedure when you said, maybe I'm interested in hormones. And so it's really important that you see someone who is knowledgeable about the thing that you care about. So look at Oprah. Oprah was having heart palpitations, and Oprah went to 5 doctors, probably the most premier cardiologists in the area, and no one gave her the diagnosis of perimenopause. Oprah had to figure it out herself. So you have to go see really menopause specialists, right? And you can find those at menopause.org, which at least gets you started, because those are people who at least are involved in the menopause societies. But it's really getting, and the person who may be comfortable doing your hormones may not know anything about vaginal health or clitoral health or testosterone, or may not know, so it's really, sometimes you need a team of people who are gonna, you gotta think of it like a pit crew. Sometimes you need mental health care. Sometimes you need pelvic floor physical therapy, and there's a team that's going to help you, right? So it's really finding the right team for you. And we do think that sometimes you have to either travel, unfortunately, or sometimes you have to go and do some virtual. There's some companies trying to do virtual care and things like that. So we have work to do on our side of training more people how to do this and how to do it at a high level, because there's a lot of low-level things happening.
Yes, absolutely. And it feels like that. So it feels confusing if you are a patient and if you are just a woman in general. And how do we take care of our anatomy that we actually don't know that much about?
So listen, this is where it's a problem. In 2022, there was a full page in the science section of the New York Times that featured us, that literally the magic science that we were presenting was that I give women a mirror and I show them their own genitals and I explain to them how they work. I say, this is your labia majora, this is your labia minora, this is your clitoris, this is your vulvar vestibule, this is how it works, this is why sex is painful, this is why, and that was science in 2022 in the New York Times, and it went viral. It was one of the most read articles in the year, which is so pathetic, right? I'm very honored that I was highlighted. It's very nice. I got a lot of press from it, but how pathetic that in 2022, right now we're 2023, that was science, right? So the fact that these are private parts, that we shield people with a sheet, that they don't even get to see what's going on down there. It's if you don't understand it, how can you advocate it for it? If you don't have the language, how can you ask for what you need or what you want or what's changing?
Oh my God, how true. And I haven't really thought about that, to be shielded, by that sheet, but that is so true. It's just amazing how little we know, and not even just, about the parts, let alone like how they work. And then what happens basically after you get to be a certain age, or even after you've had a baby, just all of it. But certainly getting into the peri-menopause and the menopause, I like how you talk about it being really the genital, you call it I'm going to get it a little bit wrong, I'm going to butcher it, but you call it a syndrome, right?
Yeah, so menopause has, I think, over 30 symptoms, right? Like this idea that it's just hot flashes and night sweats is just absurdity, right? Every cell in your body has hormone receptors in it. And so we can see things like depression, anxiety, fatigue, joint pain, burning mouth syndrome. You can see urinary frequency and urgency and urinary tract infections, pain with sex. The list goes on and on and on. And so the problem is this could start for some women in their late 30s, in their early 40s. And it kind of just like random symptoms, not everybody has the same symptoms. And so it can feel very alone. And because we don't train doctors anything about menopause, then they don't even pick up on it. And so you just get antidepressants, and you get told to eat better, and you get told to do more yoga, and you get told to just keep breathing. You're just stressed, have some more wine and just relax. And the cycle continues. And we just tell women they're hysterical because, of course, that's the answer. That's my sarcasm, of course. I hope people know that. And so what, as a urologist, what I'm trying to do is get people the awareness of the genital and urinary symptoms that happen in menopause. We call it GSM, genitourinary syndrome of menopause. And unlike the hot flashes, which for some people get better or never happen, the genital and urinary symptoms get worse and worse and worse over time. But we minimize it by saying, "Ooh, it's just a little vaginal dryness. Here's some lubricant. Just suck it up, lady. It's okay." But it's not just a little vaginal dryness. It's urinary tract infections, which can kill you. It's pain with sex, which causes divorces. It is, a change in your orgasm. I mean, it's all these things that are actually really important to people.
Hugely important. And you've mentioned that before, that urinary tract infections can kill you. I hadn't heard that until I heard you say it. How can they kill us? Because now I'm terrified.
Yeah, so, when you're young and healthy, usually you have a urinary tract infection, you take an antibiotic, you do okay. But that's not so if you're 90 and in a nursing home, right? Urinary tract infections can go to your bloodstream, can cause sepsis. In fact, if you get a lot of urinary tract infections, you become resistant to our antibiotics, which then cause you to use bigger and bigger antibiotics, maybe needing IV antibiotics. What if you no longer respond to any antibiotics and have complete resistant infections? And so actually a third of Medicare dollars are spent treating urinary tract infections, and vaginal hormones can decrease UTIs by more than half, right? Vaginal hormones, which are safe and effective for everyone, can decrease urinary tract infections by more than half.
That's amazing. So how do we get this? How do we get it? How do we get this so it can help us?
When I got out of my training, years ago, vaginal hormones were expensive. A tube of vaginal estrogen cream, which has been around since the 1970s, was like $500, right? Now it's $20. Yeah. So you can get a tube of estrogen cream for $20. You need a prescription, unfortunately. It should be over the counter, but you need a prescription. And that tube lasts about 2.5 months. You have to put at least 1 gram in the vagina every day for 2 weeks, and then twice a week. And then like your seatbelt and sunscreen, it only works if you keep using it, right? Seatbelts and sunscreen only work if you use them. So does vaginal hormone. So if it sits in your bathroom drawer, it doesn't work very well. And so some people don't like cream, so there are tablet inserts. There's vaginal DHEA, which is really great because it adds an androgen component. Because remember, women need testosterone too. And there are even rings that you can put in for 3 months at a time. So there are several options that we have available.
If you're feeling like, okay, this could be something that I need, I feel like my hormones are off, would that be going to your regular doctor and saying, please check my hormones, or going to your gynecologist and saying, please check my hormones, and then that being the thing that then has them write the prescription for the vaginal cream?
Yeah, so there's no hormone level or blood level that makes it so that you don't need this hormone cream. So if you have any symptoms of frequency, urgency, leakage, pain, dryness, discomfort, and you are peri or postmenopausal, and peri means you're still getting periods. If you have these symptoms, vaginal hormone therapy is an appropriate and evidence-based treatment for you. Now, you can show them the American Urologic Association guidelines on urinary tract infections. You can show them any blog posts that I've done or Instagram post I've done. It is safe and effective and works very well, but it only works if you keep using it. And so the problem is when women go and tell their doctors, I want hormone tests, there is no blood test that is like a fully definitive, oh, you need this thing, but you should not be denied treatment of vaginal hormones. Does that make sense?
That does make sense. And so, for the vaginal estrogen, and so you're not just prescribing that. You could be prescribing also estradiol and also testosterone, right? It could be a mix.
So you have to understand, and people really need to understand that hormones are not all the same thing. They are not all good or bad, right or wrong, dangerous or safe. There are different types of hormones. So when we're talking about the GSM or genital and urinary symptoms, we're talking about low dose, local vaginal hormone therapy that's just acting on your bladder, your vagina, and doesn't go anywhere else in your body. So it doesn't help with hot flashes or bone protection. But there is other, what we call hormone therapy, which we used to call hormone replacement therapy. Now we call menopause hormone therapy. And that is sort of whole body estrogen, whole body progesterone, and whole body testosterone. And that can look either in some cases as a cream on the skin or a patch or injections even. There's all sorts of ways to give yourself whole body hormones, but they're actually quite different.
I know certainly why my gynecologist, looked at me like I had just asked her for a back alley drug when I asked about hormone replacement therapy, is because we were told that they give you cancer. Is this true? Is there truth to that?
Yeah, so this is where hormones are not all green, black and white, good or bad, right or wrong. There's nuance here. And that study was based on garbage hormones that we don't prescribe anymore. The study had incredible flaws. And actually the study showed some really great things that hormones do. And it got totally misinterpreted. The marketing went insane. Once you have this feeling, you can't go back from it. You can't get people to change their minds, but it was not correct in the way that they explained these things. And so, what kind of medicine do we still practice from 30 years ago as dogma that we can't update our understanding that there's more updates? We don't take out appendixes the same way. We don't take out gallbladders the same way. We don't even deliver babies the same way that we did 30 years ago. And here we cannot get it out of our heads that hormones are different, and there are many people who benefit, and there are people who maybe are not the best candidates. And so that study was based on almost like a birth control pill style hormone that we don't prescribe anymore. It's not something we give people. And so when you give synthetic hormones by mouth, you can increase blood clot risk, you can increase cardiovascular issue risk, some problems can happen. When you do it through the skin, right, or you give what's called, people call bioidentical, but there's FDA approved bioidentical products, which just means we can measure it in your blood. It's the type of hormone that you can then measure in your blood. So you can do it through a patch, through a ring, through a cream, and you can increase your blood levels of hormones. There's no increased risk of blood clots. There's no increased risk of stroke. And the breast cancer data is so overblown and seems to be more based on the synthetic progestins as opposed to the estrogen itself. So when you think hormones cause cancer, estrogen causes cancer, it's hard to do in a 5-minute sort of Facebook, Instagram live, but you have to understand the data is more nuanced than that. So which is why you have to see a doctor who understands the data and can compare it to your risk, because you are not like your neighbor and you have different family histories and you have different fears and you have different goals. Because if your goal is osteoporosis prevention or your goal is good libido, then I'm going to treat you differently than if your goal is just hot flash prevention.
if someone has had cancer or has active cancer, I have come to understand that it doesn't mean that they can't take anything. Is that right? Like, it's all individual.
It's very individualized. So the thing is, so let's all take a step back for a second. I treat men.
Let's take a step back.
I am a urologist who treats men who get things like prostate cancer and all sorts of things. Men, if they say, I care the most about my ejaculate, I care the most about my erections, these are the things that are important to me, we as urologists say, that makes total sense. Let's do something differently. Let's treat you. Let's all work together to have shared decision making to do what makes sense for your body. We don't have those conversations with women. We say, you can't do this. You can't have that. You are not allowed to do this. And so my whole point is, why don't we just treat people the same way? Why don't we just give people good information, understand where their symptoms and where their fears and where their issues are coming from, and then customize a treatment that makes sense for that person?
Absolutely. That is like the whole reason I'm doing this show, is I feel like there's not enough information out there, and I want that information to be intelligent, which is why I came to you. And it's true. I mean, we have to have the information to be able to advocate for ourselves when we do go see our doctors, or when we do choose our doctors. And so seeing that all doctors don't have this training, how do we find one that does? Do we find it through ISWISH? How do we find them?
Yeah, so we're doing as much teaching and training and yelling and screaming as we can. I think it's twofold. You have to find someone who is knowledgeable, and you have to find someone who has some time to give you. And again, that's even more of a challenge in the current healthcare system with insurance models, because this is not a 5-minute conversation. And that's the frustrating thing is healthcare was designed to be 5 minutes, and your life, your nuance, your story, the things you care about, your joys is more than 5 minutes. It's much more than 5 minutes. And so ISWISH, so finding a provider, we teach a lot through ISWISH, which is the International Society for the Study of Women's Sexual Health. So it's isswsh.org. There's a find a provider. In the Menopause Society on menopause.org, there's a find a provider. But it doesn't necessarily mean that every provider in there is the right provider for you, but it's a good place to get started.
Yeah, exactly. Just kind of get the ball rolling. That's so important. I feel like, before I even built up, the courage, or really the huge pussy energy, as I would put it, to talk to my own gynecologist was, I did so much reading before I even got to that. I talked to my mom about what she took, and then it was like the door was closed. So I like to know that there are other resources. And I think that you said that you can become a patient advocate at ISWISH. Is that right?
Yeah, so the key is learning how to advocate for yourself, and learning that if one door closes doesn't mean that that person is the end of your healthcare journey. And that's where all these groups and advocacy, this is why I do so much social media, is to give people, arm them with that big energy to say, like, wait a minute, this doesn't make sense. I actually know more about this than you do as my doctor. You're going to be great for my flu shot and my lab work and this other thing that I need, but you know what? I need a sexual medicine specialist on this side, and I need a menopause specialist, and I need a team, because you deserve a team, just like you would need a cardiologist if your heart was busted, and you would need an orthopedic if your leg was busted. That like, there's not going to be one doctor that's going to be this like be all and end all for everything. I just got off the phone with a patient, and we were having to work as a team with her. I was texting with a pain doctor I'm sending to her. I was texting with another doctor. Like, sometimes you need a team to help you.
Definitely. And you talk about, investing. This is your health. Like, you've got to invest in your health and invest in your sexual health. I remember you saying, we renovate our kitchens, and we buy shoes, and we do all these things with the resources that we, have to be expended. And that this is one that is so important. And I believe that. I believe this is something that's so important for us, not just to look at as a monetary expenditure, but also as a time expenditure, so we can learn more.
So the investing is invest in the education, invest in podcasts that are really, and following me on social media helps you get access to amazing people in this space doing really great things. Because if you invest in knowledge, right? If you invest in the knowledge, then you can show up and say, wait a minute, what my doctor is saying to me is not making sense to me based on what I read. Here's this crazy concept. If you give people information on how their bodies work, they make great healthcare decisions for themselves. They can say, I would like to try estrogen, progesterone, and testosterone. You know what, Dr. Rubin? I just want to try local vaginal hormones. Or, hey, I'd like to go a non-hormonal route and try X, Y, and Z. Okay, that makes sense to me. I'm not here to tell you what to do. I'm here to be your partner and your consultant to say, hey, what about this? And I'll tell you, I'm very aggressive and pushing people because I see the future. I see women in their 50s and 60s. I had an 85-year-old patient today that I just got on the phone with, and she said every 6 months, she complains. I make her do a call with me every 6 months, and she says, Dr. Rubin, my sexual health is wonderful. I am having the best time of my life. I'm 85. I have no complaints. Give me my refills, lady. And I gave her her estrogen, her testosterone, and her vaginal estrogen. And she said, I'm great. My health is fine. I'm doing great. So it's not, right? Like it's individualized.
It is. And you're so right. Like, we really do have to invest in the knowledge and become knowledgeable so we know what to ask for. And that is the first place I'd tell someone to go, is to your Instagram, because I learned so much just going through and listening to your videos. And like you said, you know, the other people who you're talking to. I was listening to you with Rachel Gross, who wrote, Half the World Has a Clitoris, Why Don't We Study It? And that's something that I loved that you talked about, that actually you were trained as a doctor to stay away from it, right?
When you're a medical student, you do 1,000 heart exams so that you can find the murmur, right? But it's been years since I've done heart exams. You do not want me to do your heart exam, right? And so when you're a medical student, you have a day where it's standardized patients and you learn how to do a pelvic exam. And you get in there and there's 5 people per standardized patient. And you're lucky if you get one time that you get to look at that you literally put a speculum in and try to find the cervix. And that's it. That is the only chance your doctor got to practice a pelvic exam. In fact, you're told to stay away from the clitoris as not to make your patient uncomfortable, right? You don't want to make your patient. Can you imagine as a urologist if I was told to stay away from the penis to not make my patient uncomfortable? And so at no point in your doctor's training did someone say to them, here is how you examine a clitoris. Here's how you look for clitoral adhesions or clitoral phimosis. Here's what labia minora are supposed to look like. Here's what a vulvar vestibule is. We don't even teach doctors what a vulvar vestibule is, which is the entrance to the vagina, which is really why people have so much pain with penetration or urinary tract symptoms and things like that. So we don't teach that in med school. So when do you think doctors learn? And when do our patients learn what things are supposed to look like? I mean, it's a huge problem.
It is a huge problem. And I love how you also do these courses with Brooke Braylove. And she's a sex therapist. And so I like how you really connect the anatomy with the whole physiology and also just quality of life.
And again, this idea, we're working from such limited knowledge where people are actually out there thinking that most women orgasm from penetration. I mean, that couldn't be farther from the truth. Most women orgasm from clitoral stimulation. And there are people who can orgasm from penetration, and more power to them. We're all very jealous, but it is not necessarily the norm. And getting people just to understand. So when people come in with orgasm complaints, it really becomes important to understand, well, what's your anatomy? Are there any issues with your anatomy? What medications are you on? What's happening with your pelvic floor? What's happening in your brain and medications that may be affecting your brain? How's your relationship? What's going on? Where you come from? How you think about sex? What does sex look like? What do you want sex to look like, right? And that is when you make the most gains in helping people, because orgasm is very hormonally sensitive. Orgasm is very neurologically and blood flow sensitive, just the same as it is for a penis. It really is very similar.
What I love about what you do too and what you talk about is you really make that a priority, that actually having satisfaction, being able to have desire, basically being able to have sex that's not painful on the one side, and then being able to have sex that's great. And, you know, that really does contribute to our overall quality of life. And having that be, said by a medical doctor, I think has done just incredible things for the field of women's health in general. And I hope there's more people doing what you're doing. I mean, I feel like if there was a whole bunch of, little girls who were like, what should I do with my life? I'd be like, you need to watch this woman and do that.
Well, interestingly, so one of my big dreams is how can we train the next generation to care about this? And so I started a research mentorship group where we have 300 medical students that are working on projects, that are getting involved, that are doing the work. And we have publications. We've just published a paper. We published more papers. These med students are doing the work. We had a group of med students. They published all about how Chicago med school curriculums have nothing about women's sexual health. They published about clitoral adhesions. So this group of medical students is just fired up. And the more I get out there and show them that it doesn't have to look the traditional way, that you can do this and really make a huge difference for people. Listen, no one shows up to my office with a little problem. Nobody flies from across the country to come to my office to say, Dr. Rubin, my orgasm isn't happening, but I'm not bothered by it. People are bothered. They are obviously bothered, or they would not be in my office at seeing a sex doctor. And so we must take these issues seriously. We have for men. We've been taking sexual health issues for men seriously since urology was invented, right? As a urologist, I care deeply about men's sexual health issues. All I'm asking is for us to care deeply about everybody's sexual health issues.
Absolutely. I could not agree more. As also an activist for gender equality, I'm just looking for, can we just do the same amount for women as we do for men? That's it. I don't think it's that much to ask. You talk about female Viagra, and you mentioned something about how, men are encouraged to go in and talk to their regular doctors about Viagra for them. Do you want that little blue pill? And you've said there is Viagra for women, and I want to know, what is it?
Yeah, so I would say the equivalent of Viagra for women would be vaginal hormones, because what is Viagra? Viagra increases blood flow to the penis to allow for erection and make sex better. Vaginal hormones improve arousal, help with dryness, make orgasm better, right? And yet also prevent urinary tract infections. So it's Viagra that prevents it's even better than Viagra because it prevents urinary tract infections. And so I believe the equivalent of female Viagra is a vaginal estrogen or vaginal DHEA that you use to help with your arousal problems. Now, we do have FDA approved medication to help with libido, which is termed in the media as female Viagra, and it works differently. It doesn't work. It works for about 60% of people, but it's not the same thing. And we also give Viagra to women. How does it work? By increasing blood flow to the clitoris. So women can take Viagra and Cialis, and it works by increasing blood flow to the clitoris. It's just that a lot of women are more bothered by their libido, their desire levels, their brain, as opposed to they're not getting enough blood flow to the clitoris. But I find it works very well with people on antidepressants having a delayed orgasm. I think it works very well as synergy. So say you're on vaginal hormones and you're on whole body hormones, and you just need a little bit more oomph, your orgasm's a little muted. We love Viagra and Cialis for those patients.
How about what we can do for our pelvic floors, right? There's so much about pelvic floor health these days where it's like we've just become aware that we kind of have one. And, I feel like Kegels have been the answer, like for every question. Like, oh, this hurts, do some Kegels, right? Or you just had a baby, let's do some Kegels. Now that we've got pelvic floor health, you talk about actually going to rehab. I think you said that actually having a baby is an insult to your musculoskeletal system. And I thought, wow, that's really interesting. And so you talk about actually going to rehab. You're like, after you get a knee replacement, you go to rehab. After you get a hip replacement, you go to rehab. So why aren't we rehabbing our pelvic floors? How do we know that we need to go rehab them?
Well, I say if you have a pelvis, it needs rehab, right? That's kind of the answer. So in France, for example, if you have a baby, you are automatically signed up for pelvic floor physical therapy. And so it should be standard of care in the United States as well. It's just that we don't have insurance companies covering it at the same level they should, nor do we have enough pelvic floor physical therapists to take care of half the population. But let's be real. If a baby is increasing in your uterus, it's filling up that whole space. It's expanding your abdominal wall muscles. It's pushing on your pelvic floor muscles. It's going to increase your likelihood of leakage and back pain and low back pain and hip pain and all of those things. So why wouldn't you need rehab? Of course you do. It's a huge hormonal fluctuation, and it's a huge musculoskeletal shift. And just because we've never done something before doesn't mean we shouldn't, right? Like, yes, women have been having babies for, since women existed, but women have also been needing rehab since before, right? Since the dawn of time.
Yeah. And so what does a course of rehab look like? Is this like, a few months where you're going in 2 times a week and somebody's kind of telling you what to do? Like, what does pelvic floor rehab look like?
Yeah, so it can look a lot of different ways, and it gets very customized to what you need. Because just like you're saying, everyone's told to Kegel, but not everyone needs to Kegel. Some people need to reverse Kegel. Some people need to learn how to relax. Did you know your hip and your vagina were connected, by the way? If you
not until I started listening to you.
Okay, so if you put a finger in the vagina and you move your leg back and forth to move your hip, you'll feel a muscle pop out at you. That's your hip muscle. Your vagina and your hips are connected completely. And so if you're like 80 and you've got a hip issue, yeah, sex might be painful, or sitting might be painful, or wearing pants might be painful because your hip bone is connected to your vagina, right? So it's understanding. So what does it look like? It totally depends. Sometimes it's working on breathing and sitting and posture. Sometimes it's working on relaxing the muscles or strengthening the muscles, or doing both. And so working with these professionals, and they are really amazing, and there are multiple websites that you can find a pelvic floor physical therapist. The American Physical Therapy Association has a great find a provider. And so they are incredible, and they can really work with you to find sort of what you need and what rehab strategy you need.
Okay, because when I think about it, I think, okay, like, is this the kind of rehab that you've got clothes on or not, right? Like, is there something that is entering your vagina during pelvic rehab, or is it like I'm, like you said, so posture again, and sitting? Could it be like that?
So that different? When you first meet them, there's a lot of intake talking. There's a lot of talking. They buy you dinner first before they make you undress. I'm just kidding. There's a lot of talking and figuring out what you need and meeting you where you are. If you're someone who has a trauma history, they're not going to rush into doing something that is painful or traumatic for you, and they meet you where you are. But just like if you have tension in your neck and need to release those muscles, if you have problems in the muscles that surround the vagina, there may be a finger that is placed to like feel and palpate and see and release the tension there. But again, it's different for everybody of what each person needs. And so it's really understanding that you wouldn't worry if it was your shoulder muscles that were being sort of evaluated. And just as your shoulder can have problems, your muscles in your pelvis can have problems.
I mean, it is all connected. It really is. You talked about how hormones are connected to your spinal cord. Something's connected to your spinal cord. And I was like, oh, wow, I did not know that.
Let's think, you're the clitoris lady, so let's think about orgasm for a second. Orgasm is a reflex, right? You have to have a perfect reflex between your clitoris and your brain and back down. And how does that get connected? It's through your spinal cord. And so there are people who have spinal pathologies that can affect their clitoris, their vagina, their vulva, their bladder, their pelvic health. And so the problem is the spine community, the neurologists, the spine surgeons, they don't think about vaginas or bladders or urethras. And so they're kind of ignoring the fact that sciatica can not just be in your leg, but can be in your pelvis too. And so the spine is uniquely connected to sexual organs and bladder and bowels. So what we'll see is not just sexual dysfunction, we'll see bladder symptoms, we'll see bowel symptoms, and it's often a neurological thing about the nerves that are coming from the spinal cord that are innervating these organs.
And by innervating, and I love this word, it's basically creating blood flow, right?
By innervating, well, by nerves, it tells the muscles to contract or relax or to do something. So nerves are the thing that tell the system to work. So it tells the muscles. Now, hormones are needed to keep the muscles healthy, to keep the tissue healthy. The nerves tell everything how to feel, how to function, how to, does that make sense?
It does. And as I'm thinking about, things connected to the brain, I want to kind of touch on peri-menopause, menopause, and how that affects depression. Basically, how that affects our mental health, how it can affect our mental health, how we can know, do I need that antidepressant? Or basically, do I need to come see you?
Well, it's very important. This answer is sometimes both, and it takes getting to know you personally. Now, data shows that peri-menopause is a big time when anxiety and depression can pop up, and we see an amazing benefit of hormone therapy in helping with mental health. Now, that doesn't mean that nobody needs an antidepressant. Antidepressants can be extremely helpful for people in need, but they can also have sexual side effects, right? So antidepressants can delay orgasm or lower libido. And so we're constantly playing sort of a juggling to figure out what is the benefits and what are the risks to different therapies. And so we see a lot of hormonal changes like premenstrual symptoms that can be because of a lowering of hormones in certain areas. So there's a lot of hormonal fluctuations that can create mental health conditions. And it's really important that we understand the connection and that you see someone who's going to work collaboratively with your mental health person.
Right. And not just keep them as separate buckets that never kind of come together in the same bucket.
I'm getting hammer texted by my mentor, so you should have him on the podcast. He's unbelievable. So my mentor,
well, he's down here.
He's in San Diego. No, he's in San Diego.
Yes.
He invented Viagra. He created the field of women's sexual health. He is like one of the most brilliant people in the world. He's literally texting me, calling me nonstop because I sent him a patient with a spinal condition, and he was excited to tell me that they did testing on her to do a numbing block, and now she has no pain, and that it's working, and that there is this connection between her sexual symptoms and her spinal pathologies. And this is like, we are so excited about these innovations that we're learning about.
Wow.
And it's pretty, so I'm just trying to tell him to leave me alone because I'm on a live session, but he keeps calling me like an excited person would. He wants me to answer.
I love that. What was the thing that made you want to go and do the fellowship with him? What was the thing, you went to medical school. Did you always know you wanted to do this? Or did something shift in your life that you were like, I'm going to go in the direction of sexual medicine?
Yeah, I was very interested in, I think these issues were always easy for us to talk about among my friends in middle school and high school, and we were good at talking about this stuff. And then I went into the real world and found out that was weird. Like, we were weird for being comfortable doing those things. Like, we're all a bunch of weirdos. And so I gravitated toward, I have a sense of humor of like a middle schooler. So penis jokes and urology was very in tune with my sense of humor and what I like to do. And here was a field where you could do quality of life medicine. And then I found Dr. Goldstein through urology, and really once you hear him speak once, it changes your life, and it really took one lecture for me to say, oh yeah, no, this is what I'm going to do with the rest of my life.
That's amazing. And so what did the fellowship look like? Is that multi-year? Is that kind of like going into another residency?
No, it was a one-year fellowship, but really we joke that I'm the lifelong fellow because it's such a cool field that is wide open. And so we have unlimited questions. We have so much research that we need, and we need all hands on deck. And so it is really rising tides lift all boats, and we all work so collaboratively together because we don't even understand labia minora in science today. We don't understand what all the nerves are to the genitals. It's not really clear cut. There are basic things that we should have figured out by now, but no one's ever looked at them. And so we did a project on clitoral adhesions where we found that 25% of all women, their clitorises are stuck. The hood and the head of the clitoris are kind of stuck together. And we did a project where when you unstick it and you do a lysis of adhesion, we improved orgasm by 60%. We improved arousal by 70%, right? We improved pain with clitoral touch. So for all those people who are saying, ooh, I don't like the way oral sex feels, or I don't like the way hands feel, it's not always up in here. It's sometimes an actual physical problem, that happens. And we just published on that a year ago. Why have we not figured that out by now, right? Why has that never been looked at?
Oh my God. That's That's pretty amazing. It makes me think about the letter that you sent to me, that you shared with me from a patient who had unfortunately gotten a labiaplasty that did not go well. And that would absolutely be connected to the fact that we don't know enough about this stuff. So how do you feel about people going in and getting labiaplasties? Are they safe?
The answer is we don't know, right? And the teaching, the textbooks do not even show the full nerve anatomy of this area. We don't have enough information, nor is there really training. There are very few people who are fully trained in labiaplasty procedures to the degree that probably is important to be trained. We just think, oh, here's an extra flap of tissue, let's just cut it off. And sometimes it goes well, and sometimes people are happy, and I'm all about body autonomy, and you should get to decide what happens to your body. But if you are not properly given the risks of, hey, this could hurt a nerve, that could lead you numb, that could affect your arousal and your orgasm, right? You have to be able to take that risk and say, you told me, doc, I still want to go proceed with this surgery.
Right, absolutely. So then that comes back to really having the knowledge as a patient, asking your doctor, what is your training? How many of these have you done? Have you ever, had nerve problems from one of these? Just asking those questions, right?
And the thing is there will always be complications in surgery. We will always hurt people, right? There is never there's actually sometimes risk of not doing, there's a risk of not taking hormone therapy. There's a risk of taking hormone therapy. There is a risk of having surgery, and there are risks of not having surgery. There's always risk. Bad things will always happen. The question is what happens when you're that 1 in a million person? It's no fun. And then you come into we're there to help take care of you, but we can't always fix it and make everything perfect.
So true. And having that, that risk, really understanding risk, because like we've talked about with hormones, sure, there may be a risk in this, but is your risk worse if you don't take them? And that's important for us to know too. And so would you say that, it's, if you get to a certain age, that vaginal estrogen is good for everybody, period? Or does it really depend on what you've got going on?
So there's one situation where I would say I think it benefits everybody, period, end of sentence. However, there are certain formulations that may irritate different people. It has to be to find the right thing that works for you, right? So sometimes creams are irritating. Sometimes this product doesn't work for you, that product. So it doesn't mean it doesn't work. It just means we may have to tinker and get the formulation right. So I would say nothing is always for everybody, but this is something that really a huge majority of people would benefit in using.
How often do you do your menopause Zoom group visits where people from all over, because you're based in DC, so if I'm not based in DC and I can't come see you in person, how often can I learn from you in terms of these Zooms that you're doing specifically about menopause?
What's funny is we actually can't get as many people to sign up as we want to because people don't even know that they need this information, right? And they want it all for free, and they want it all customized and with their $5 copay, and they want it all just right there, and they want so they're really, it's really hard even to get people to come and to say, hey, you need to learn about this. But the reason I do them is because it's our waiting list is quite long. And so I'm trying to get people together in community and then individual care to kind of streamline some of the knowledge piece of it. But it's not working. It's not actually working very well. And so I think we need to reimagine the scale at which we do these things. But the problem is what you hear in a webinar doesn't apply to you. And then what you hear in a 10-minute doctor's visit isn't enough for you. And so the question is, how do you mix the two of giving you the very significant large amount of information that you need to hear, but also understand that you actually need it customized to your individual story?
Oh, so true. That makes me think that we just have to actually rethink how we think about healthcare, putting all the onus on the doctor and just saying, what do I do? That doesn't seem reasonable because, like we've talked about, the doctor may not even have training in that area. So I think we need to know more. right? We need to gather more information.
And right, think about it. Think of if you go to the doctor and you say, I want this laser procedure that I read about on your website, and you go in there, the doctor's going to say, great, let's do the laser procedure. Instead of saying, wait a minute. You're 48, you're having hot flashes and brain fog and all this other stuff. Sure, we can talk about the laser procedure, but we need to have a bigger conversation here and talk about X, Y, and Z. No doctor's going to do that. Well, some of us do, but most doctors don't do that because they're like, well, I only got 10 minutes. So you want the laser? Let's go do the laser. And they laser focus in on the one issue and they miss the whole thing. They miss the fact that it's all because of one thing. So we see this all the time. Women will say, well, I went to the cardiologist and I went to the rheumatologist and I went to the endocrine doctor and I went to the neurologist, and none of them picked up on the fact that it was all menopause the whole time, and none were ready to offer hormone therapy because no one ever taught them how to do it.
That's why I really started with the most simple question ever, which is like, how do we know we're in menopause? Because we could be going and getting some laser treatment that doesn't really help us at all. And you've talked about, things that are Band-Aids versus really healing. Like, let's go to the problem and heal the problem instead of let's just, slap a Band-Aid on it and walk on by, right? And then have to get another laser procedure or then have to get some surgery redone.
And people are being sold shiny things that they're hoping solve all their problems. It's like Botox so that your face doesn't move, which is fine. Do all the Botox you want. But what about estrogen, which actually helps the collagen in your skin and actually fixes the problem, but also helps your bones stay strong and all of those things. So what I tell patients all the time is, as long as we're doing the foundational elements, go get whatever shiny new laser or new technology. There is some reasonable evidence for some of them. But again, it's experimental. And you have to say that as, ooh, I want to do the latest and greatest thing that I think will be helpful. But are you doing the foundational things that are safe, that are evidence-based, that are effective? And you don't necessarily need to spend a lot of money because there are FDA-approved bioidentical hormones. There are FDA-approved vaginal hormone therapies that actually a lot will be covered by your insurance and can work quite well.
Okay, and so those foundational things, that would be the hormones. That would be this vaginal estrogen cream that you talked about that used to be $500 and now it's $20. Is that right?
Exactly. So it may be whole body hormone therapy. It may be vaginal hormones, either estrogen or DHEA. There are multiple products of different kinds that may be the right treatment. Again, not a one size fits all. I'm not here saying everybody needs these things, but everybody needs someone paying attention to their whole selves to say, what of these symptoms actually are perimenopausal, and what are the true risks of hormones, and what are what could we do? And also, if you make a decision, like what you do today is not necessarily what you always have to do. We may change, right? And all my patients always say is you're a moving target in perimenopause, as things are changing and we got to follow you where you go.
Totally. I mean, I feel like I didn't even hear the term perimenopause until like a couple of years ago. It wasn't something that was even on my radar as something that could be coming up to kind of prepare yourself or get knowledgeable about.
It's right. The what to expect when no longer expecting, right? This idea we don't even warn people about. You sort of think, golden girls, you think gray haired, you think grandma, and like, look at Jane Fonda, like she's like in her 80s and she's doing great. Like that's hormone therapy, baby, right? Like you got to understand that it's and it will happen to everyone. This is the thing that like you think, oh, well, I eat well, I do yoga, I breathe, I'm all mindful, I'm clean eating, I'm counting my macros, I'm doing all that. It's not going to fix, it's not going to prevent your ovaries from no longer producing hormones.
And so how about on the patient side of changing things, yes, advocating for ourselves, but then also how can we as patients or I'll just say like as activists for women's health, really. I think if you're a patient, you're an activist for women's health. If you're just caring about your health, I'm just going to put you in the activist community. We want more doctors to have training, and we want them to have great training like you have. What can we do on that side? Is that like become, a patient advocate at ISWISH, or is that really talking to our provider and saying, please go get this training?
Yeah, so this is where getting involved, getting loud, a couple resources that are helpful. First and foremost, knowledge. Gain all the knowledge, do all the listening, all the reading, and the most important thing you can do is talk to all your friends about it, right? The more you can educate your friends, the better.
I mean, you're changing lives. The letter that you read aloud on your Instagram, which I love, you're completely changing people's lives. And from what I know about your practice, are you an all-female practice or are you mixed?
Right now, we're all women. Our business is exploding and it's busy and fun and amazing. And I'm telling you, I'm having the most fun of my life. We've got a lot of work to do. And there is no shortage of people who are just looking to get help here.
What do you do from that standpoint? Because I can understand that your waiting list must be just like years and years and years. So do you refer people to other people?
We do, but we have my brilliant colleague who I've hired, who trained me and I trained. We've trained each other. Who's a urologist, is helping me, Dr. Catherine Kloss. So she's got openings. We're reimagining the whole thing and trying to see how we can help as many people as possible. This is why I come and I give as much free education as I can. I'm not hiding anything or holding anything back. The more I can empower doctors and clinicians to do this at a high level, just the better everything's going to be. So again, going to iswish.org and find a provider, or menopause.org and find a provider. I have brilliant colleagues all over the place who are really doing meaningful, wonderful work.
Oh my God. I feel like you're just changing the face of women's health. Really, truly. It's like, really, I can't even say enough about it. I love what you're doing. I love the way you're doing it, because it really does empower us as women to get knowledgeable and to become our own advocates for our healthcare, which is so incredibly important because we are behind when it comes to women's health, like a lot. And I think that, a lot is changing. I mean, you're absolutely changing how it's done. And that is just tremendously exciting to me to just know that you're out there changing things. So I just want to say, seriously, I'll get choked up saying it, but thank you for what you're doing.
Well, thank you for giving a platform to people. And this is where it's literally, we are all needed here. And this is, I think I'm good at this because I'm able to say, well, we don't know. Science hasn't looked at this yet. We're at the edge. We have no clue. And that's unacceptable in 2023 that we don't know about very easy things that we should know about. And so it's just giving permission to people to say it's okay to care about your libido. It's okay to care about your orgasm. It's okay to care about your sexual health, because it is just healthcare like anything else. And so you have to sometimes advocate and seek it out, but you deserve to optimize your best life in whatever way you want to.
If I, could wave a wand and change something in my lifetime, it would be to get rid of the stigma around female sexuality, which is, I have a foundation that's really about making media that goes in that direction, that's how this podcast exists. And you're doing so much for that, really just stamping out that stigma. So you say sexual health is healthcare, right? It is health, period. It's no different than our, brain health or our heart health or anything else. And that is so important, I think, for us to know. And I feel like we just need to hear it a lot so it just gets in our heads.
No, this has been so wonderful. Thank you so much for having me. This is really...
Oh my God. Thank you so much for taking the time. I know how busy you are. I mean, truly, when you'd email me back one word, I'd be like, oh my God. It was just so exciting. My daughter knows who you are. Everybody who knows me knows who you are. I've just been talking about you ever since I read that article. And I was like, this woman is changing the world. I just thank you so much for what you're doing. Thank you, thank you, thank you.
Bye.
I'm Jacqueline Buckingham. Welcome to your most powerful chapter. Wherever you are on the pause spectrum, this is where you begin. Go to joinmeno.com and get early access. These are the answers, and we bring you the experts that have them.